Symptoms: jaundice, dark urine. Paleness may precede jaundice. Fatigue. Abdominal pain. Signs: jaundice, pallor, splenomegaly, fever. Investigations: complete blood count. The hemoglobin is moderately to markedly decreased. The total leukocyte count may be moderately elevated with a shift to the left. The platelet count is normal. The mean cell volume is normal. Respiratory count, increased with erythrocyte destruction, may be low at onset of disease. Peripheral blood smear, erythrocyte morphology significant for microspherocytes. Polychromasia, nucleated erythrocytes. There are no erythrocyte fragments. Direct antiglobulin test, direct Coombs test positive usually for IgG. Most autoimmune hemolytic anemia of childhood is warm reacting. Indirect antiglobulin test, indirect Coombs test positive for antibody in the serum. Special bone marrow aspiration, performed if there is a suspicion of concomitant malignancy. Complications: severe, rapidly developing anemia may lead to heart failure, shock, erythrocyte incompatibility and in vivo erythrocyte destruction, causing difficulty in treating severe anemia with transfusion treatment. Diet and lifestyle. No specific dietary recommendations are necessary. Acutely anemic require hospitalization and bed rest with careful monitoring of vital signs and evidence of ongoing hemolysis. Once discharged from hospital, activity as tolerated is recommended. Pharmacologic treatment. Standard dosage methylprednisone, 0.5 to 1.0 mg/kg/day in 4 divided doses in the acute phase of hemolysis. Prednisone, maintenance dose of 2 mg per kilogram until hemoglobin approaches normal. Special points methylprednisolone, when stable may change to oral. Corticosteroid treatment aims to stop immune-mediated hemolysis and maintain a normal hemoglobin and a normal respiratory count. Other treatments: intravenous immunoglobulin, 1 gm/kg if corticosteroid does not slow rate of hemolysis. Erythrocyte transfusion may be required. In severe, life-threatening anemia, erythrocyte units may not be compatible, in which case a portion of a least incompatible erythrocyte unit is slowly transfused. Patient should be monitored for intravascular hemolysis, plasmapheresis, to remove IgG, splenectomy, effective in IgG-mediated hemolytic anemia, reserved for resistant cases. Immunosuppressive agents, vincristine, cyclophosphamide, reserved for cases unresponsive to other therapies. Prognosis: mortality, 10% due to acute onset of severe anemia. Complete resolution in majority of patients in 3 to 6 mo. Chronic course may develop in those 2Y or greater than 12Y at presentation. Follow-up and management. Patients with chronic hemolysis should be followed with complete blood count. Respiratory counts. Patients who require splenectomy should take penicillin prophylaxis to prevent post-splenectomy sepsis.